So the more we know about the human immune system, the more we can look at these independent therapies, and as you say, it's a combination therapy, and start to, I guess, some people refer to it as maybe a cocktail or a combination therapy. Are we going to see more and more of that as we go forward and we learn more about the immune system?
Absolutely. I think another area of immuno-oncology is what are called checkpoint inhibitors. So these are drugs, nivolumab, pembrolizumab, durvalumab. There's a bunch of them in development or or approved for other diseases right now, where you're essentially taking the brakes off the body's immune system to allow it to go after the cancer cell. And what we're seeing in many areas, at this meeting there are presentations on acute leukemia, chronic leukemia, multiple myeloma, lymphoma. Combining that approach with other therapies seems to be a very promising way. So I think we are going to see more and more combinations, and the real questions I think are going to be, what are the best combinations that maximize response rates, maximize patients living longer with their diseases or curing them, versus side effects and also costs. These are all very expensive medications right now, and that's, I think, as you get into combinations, that's going to become a bigger and bigger issue for people.
Yeah. So you're involved in a lot of research studies. I get a lot of calls or a lot of emails from our community, and they're asking about clinical trials. And there is a lot of myths that we need to dispel about clinical trials. And the one thing I hear the most is, if I enter a clinical trial and I'm not getting the medication, am I getting some substandard care if I get the placebo? Right. Exactly. And so, I address it as no. When you're in a clinical study, you're actually getting the treatment that's currently there for that, what you're being treated for. But from a clinical perspective, what do you tell patients when they come, or what advice could you give our community about somebody thinking about getting into a clinical study?
Absolutely. I think that's a great question. That's a common misconception that I talk to patients about all the time. So I think clinical trials are great opportunities for patients for two reasons. One is that that's how all these new drugs get approved, so there's sort of a societal benefit. But number two, particularly if it's a medication that's already shown promise in earlier studies, it's often a chance to get that medication a year or two or more before it's actually approved. And that's, for me, one of the most gratifying things, is take these medications that look so promising, to try them in people and see, wow, these are really amazing results. With respect to your question about the placebo control or randomization, so studies come in two flavors. One is what's called a single-arm study, where everybody in the study gets the same medication. Those are usually earlier on, where we're trying to get an early sense of whether this treatment works or not. Usually before you can get FDA approval or get the drug out there, you really have to compare it in a randomized fashion to whatever the standard of care is. And the idea is you take a group of patients and you randomly assign them to the study arm, the experimental treatment, or the standard treatment. And that's the only way you're really going to know whether your study treatment is better. And it's a big issue, because if these treatments cost $10,000 a month and it's not effective, that's not a good use of anyone's healthcare dollars. It's also, if there are side effects and you're exposing someone to side effects for a treatment that doesn't work, that's not a good thing either. So that's where the rationale for the randomization comes in. And it is important to understand that the standard arm, the control arm of the study, should never be less than the standard of care. So I would never put a patient in study, our institution would never approve a study or accept a study where we felt that the standard of care arm was substandard. So what I always tell patients is, you're going to get the standard, you either will get the standard treatment or you'll get something that we think may be better. Now, we don't know that it's better, because that's why we're doing the research, but we hypothesize that that treatment is going to be better. Sometimes there are studies that look at doing less. There are some studies that say, we think we're over-treating patients, particularly with chemotherapy drugs. Could we back off on that in certain patients and get the same results? So there are some cases where you might be getting an experimental arm that's less than the standard arm, but only because we think that maybe you don't need as much chemotherapy and the side effect profile will be better. Yeah. But that is an important point. I always tell patients, you will never get less than the standard, and you can always discontinue or come off the study whenever you want, and it's not going to affect your care. That's an important part of kind of patients' rights and things like that.
Yeah, absolutely. Well, Dr. Andorski, thank you once again for stopping by and everything that you're doing. I appreciate it.
Great.
Thank you.
Thank you.